everyone, and welcome to the May 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Brickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
Welcome to May, everyone. I am personally looking forward to May flowers and saying April showers bring May flowers. Alice, how's your spring going?
It's going well so far. I'm still sort of waiting for it to show up, although I have to say in Toronto, it has gotten a little bit warmer. But then I have not changed out of my winter tires because I got yelled at the last time I did that too early. So I am going to hold out until it's far more consistent because you never know up here, I got to say.
Yeah, and April's one of those months, right, where it can go from unseasonably warm to unseasonably cold again. And I guess in Canada, things can still be pretty cold, but we've got the daffodils and the tulips blooming. So it's certainly been finally feeling warm enough down here in Pennsylvania.
Excellent. Good to hear. I have hope. So, Mike, are you ready for the question this month?
I think so.
All right. So this is a good one. What is the best advice that a coworker or a mentor has ever given you?
Okay, that is a good question, Alice. And I would say best advice is going to be tough for me since I've certainly been privileged to have received lots of great advice over the years from a number of colleagues and mentors. But a simple piece of advice that comes to mind and came from my fellowship endocrinology mentor and now colleague at Penn, Peter Snyder, is never skip a step. No matter how tempting it might be, skipping a step in whatever process will always end up making that process take longer, not shorter. And while this was shared in the context of performing a diagnostic evaluation in the clinic, this advice I feel is applied as well to ensuring rigor and reproducibility in science. And so something I continue to think about quite a lot. How about you, Alice?
That's really good, Mike. I really like that. I really like that. Thank you for sharing that. For me, same with you. I've gotten lots of great advice over the course of my career thus far. The one that I think stands out at the moment is that every bad thing that occurs will end up being a great story in the future. So this was from Herzl Gerstein, who many of you know, an endocrinologist and wonderful researcher from McMaster University in Hamilton in Canada. And it's in the context, over the course of one's career, things happen that you didn't want to happen or something negative may happen. And at the time, it can feel like the end of the world. It can feel like the most catastrophic thing. How am I going to possibly recover from this? But at the end of the day, what ends up happening is you do survive it, and then it ends up making a great story in the future for something that you can share with other colleagues or with mentees. And I always bear that in mind. If something sort of doesn't go according to plan, you know what? It may not feel great right now, but it's going to end up making a great story in the future.
Indeed, and that's a very positive way to looking at setbacks and unexpected outcomes and embracing the serendipity that often comes out of those experiences and providing a new path to follow that hadn't been thought of before. So I think that's great. Well, on that note, why don't we launch into the May 2026 episode of Diabetes Care on Air? Alice and I will each conduct an interview with authors of feature articles as per our usual, and that'll be followed by a rapid exchange segment where we'll each pick 3 articles of particular interest to us.
And to quote Walt Disney, the way to get started is to quit talking to begin doing. Although technically our version of doing is actually talking, so I probably picked the wrong quote, didn't I? But oh well, let's move on. One of the feature articles from the May 2026 issue of Diabetes Care is an excellent Perspectives in Care entitled Why Early Large-Scale Weight Loss is the Future of Type 2 Diabetes Care by Professors Naveed Sattar and John Buse. I'm thrilled to be joined by Professor Naveed Sattar, Professor of Cardiometabolic Medicine and Honorary Consultant at the University of Glasgow. Great to have you on the podcast again, Naveed. In fact, I think the last time was March 2025, so it's becoming like an annual thing for you. So, congratulations to you and John for this important feature article.
Well, thank you, Alice. It's always a pleasure to speak to you and to the diabetes care community. I mean, it's a privilege to be part of it.
Well, let's launch right in. So, why did you and John feel that this perspectives in care was important to write? Because don't we already know that weight loss is important in type 2 diabetes management as outlined in the ADA EASD consensus?
No, we do, Alice, absolutely. And I think part of the stimulus for obesity becoming more prominent even in that guideline was the brilliant paper by Ildi Lingvi and colleagues in 2002 in The Lancet, which really, sort of set forward a hypothesis or a suggestion that actually obesity should be almost the primary target in diabetes. And, that paper picked up a lot of interest. I was thinking about the same things, similarly looking at the same levels of data as LD and colleagues were and coming to the same conclusions. But obviously, having done direct and few other trials and looked at the evidence from epidemiology and other aspects, it became even clearer that actually obesity shouldn't just be one of the pillars, it should be the main pillar. And now that we have tools to be able to do that, that looks like it's going to be the future of care in people with type 2 diabetes. Not everybody, but perhaps the vast majority.
Now, within your paper, you talk about proposing both early and large scale in terms of the weight management or weight loss. So let's lay out some of the arguments supporting this proposal. And you begin by reminding us that type 2 diabetes is a disease of excess adiposity that is reversible with intentional weight loss. So, what kind of evidence supports this statement? And how do age, sex, ethnicity, and genetics play into this? Because as you already alluded to, this is not necessarily a pillar for everyone. So how do those other things play into this?
Yeah, so the beauty of medicine and doing lots of different types of research is that you have the privilege of looking at lots of data, try and triangulate it. So let me start from the front. Epidemiologically, the evidence linking BMI to type 2 diabetes is incredibly strong. Hazard ratios, living with obesity versus normal, up to 20-fold higher, which suggests it's causal. Anything that's above 10 tells you it's likely causal. We've done some Mendelian randomization led by some of my brilliant colleagues, Hanaya Yukta, where actually the genetics suggest that obesity or excess ectopic fat within the liver is causal for diabetes. So you've got epidemiology, genetics. And then if you look at all the trial evidence of weight loss trials that we've done in Glasgow or Qatar or other parts of the world, and you put them together in terms of on the x-axis the percentage weight loss and the y-axis percentage remission, whether that's for complete remission or partial remission, they're straight lines. They're absolutely straight lines. And that includes people who are white Scottish people, Qataris, South Asians living in Glasgow from Pakistan origin, Afro-Caribbeans in islands in Jamaica. So it looks pretty convincing. And I think from all of that triangulating evidence and also in clinical practice, you and I know that if we see people lose weight, often their hemoglobin A1 will improve in almost parallel as they lose weight. And if they put the weight back on, it will go back up again. And then you add further sort of dimensions to age. Younger people have got more muscle mass. They are able to store fat with more subcutaneous tissue, and they have younger pancreases. So they need to have a much bigger level of obesity to overcome their sort of metabolic buffering capacity, shall we say. But with greater obesity also comes many other risk factors as well. So younger people, obesity needs to be much greater to develop type 2. In sex terms or gender terms, women have more subcutaneous fat capacity, and therefore they have to put on even more weight to start to put the fat into the wrong areas, i.e. into the liver, muscle, pancreas, ectopic organs, as it were, which is why more men get diabetes in middle age than women, and that's clear-cut nearly in every ethnicity around the world. And in terms of ethnicity, if I look at myself, I have a family history of diabetes. I'm South Asian. South Asians put more fat ectopically, and therefore we need to put on less weight to get diabetes. Other ethnicities compared to whites may have dysfunctional insulin capacity. Again, if you therefore, for less ectopic fat and insulin resistance, they will get diabetes or they have dysfunctional insulin. But whatever your potential, it's usually to a greater or lesser extent, it's excess weight gain that pulls the trigger to developing the hypoglycemia, which is what we then in care practice diagnose diabetes and treat people with type 2 diabetes. But I would say, of course, lots of the harm for some other aspects has already begun well before the sugar actually starts to elevate into the frank diabetes range.
And within the paper, you use the term personal threshold, which I really liked. It's sort of the idea of a personal threshold of the amount of excess adiposity, because as you just said, depending on who you are, you need a different amount in order to develop the metabolic complications.
Yeah, and I should give a shout out here to Roy Taylor, who's championed that. But I would also say that level of threshold changes with age. So if I was 30 years younger, which I was, I could probably put on a lot more weight because by then I would have had more muscle mass. My pancreas is younger. So it does change with age, and I think that's important to remember as well.
So you do talk about early weight loss being a critical component. So how does the timing of the intervention impact insulin sensitivity and beta cell function?
So I actually put it a different way. The reason early is because diabetes is a condition when you develop it in most people, they've already had lots of ectopic fat and excess fluid and high blood pressure even before the diabetes comes on. And then you've got the dysglycemia, which adds even more risk. So if we want to then stop that excess risk factor or toxic fuel being present in our body to a higher level than we would want it to be otherwise, to start to cause damage to the eyes, kidneys, and other small blood vessels or large blood vessels, keeping the sugar low and preventing an aggregated exposure matters. So early is good. It will stop that excess risk. It will also mean that people get that intervention at the time where there's lots of the organ systems, including eyes, including nerves, including kidneys, have not been damaged. So they have a greater capacity to actually improve their lifestyle once they get considerable weight loss as well. So I think that's the evidence. And the other evidence appears to be from the surgical evidence, from the randomized trial evidence of low-calorie diets, is that the earlier you intervene, the more likely you are to be able to get remission as well. And then probably the final piece of evidence, if you think then, if we start talking about tools like incretins, there is some evidence, I wouldn't say it's definitive, which we published, that the lower the hemoglobin A1c in diabetes, when you give an incretin, the more weight loss you get as well. So if you triangulate all of that together, it absolutely makes sense you do it early. And if anything, to prevent the insurance hit of type 2 diabetes, we probably, if we could afford it, would want to do it in pre-diabetes. But that's perhaps another debate for future.
Right. And you've already alluded to this somewhat, but the benefits of intentional weight loss in type 2 diabetes are beyond glycemia, right? So what are the other benefits?
Well beyond. And this is where I think, if you read the paper and you read lots of new evidence coming forward, we have substantially under-recognized the importance of obesity on multiple risk factors. I sit here, and I'm privileged to do what I do, but I'm a South Asian with a family history of cardiovascular disease, and I have subclinical coronary disease, and I know that I was a bit heavier, and I don't have diabetes as yet. I was heavier in my 20s to 40s. My triglyceride was higher, and triglycerides begets remnant particles, which are atherogenic. In fact, it's been calculated using genetics that a remnant particle, even though they're much less preponderant than LDL, which is why we tend not to focus on them, but if you do have lots of them, they are 5 times more toxic to the blood vessels than our LDL. So I probably had many years of higher remnants, which accelerated my atherosclerosis. In addition, many younger people, if you put on weight, at the same time as you're eating excess calories, you're taking in more salt. And with salt follows fluid. And we now know that many people living with diabetes have got excess fluid in their body, which leads to more pressure on your pumps, pipes, and your filters, your kidneys and your heart and your blood vessels. In addition, we know that obesity is linked to systemic inflammation. We don't know where, but clearly when there's adipose tissue in places where it shouldn't be, it begets an inflammatory reaction. You get more macrophages and immune cells that spew out IL-6, and we know that IL-6 from genetics looks like it is irritating blood vessels and accelerating other atherogenic processes. And there's 2 other factors that perhaps people haven't thought about there's actually multiple others actually. With obesity comes more thrombogenicity, stickier blood, which accelerates atherogenesis and other aspects. And more recently, we've now recognized that obesity is a strong risk factor for infections. And for years we thought, wow, type 2 diabetes, infections, hypoglycemia. But actually, maybe the obesity was also relevant to the infections. And there's emerging evidence from the randomized trials from select, and I think there'll be other evidence coming from another major randomized trial, that when you treat and get the weight down, you substantially reduce the risk of infection. So that's just a small, well, not small, that's a kind of the core elements. So, and I suppose the final element is, by the time 20 years before you develop type 2 diabetes, because you're actually over a period of 10 to 20 years putting on ectopic fat and excess fluid, cardiovascular risk is already double 25 years before most people develop type 2 diabetes. So the risks are already there. And then the hypoglycemia comes, accelerates that risk in different ways. But it's the obesity that sets in train so many risk factors well in advance. And you continue to do that once you develop diabetes, and the sugar then interacts with all these other risk factors to further accelerate risk. So it's the obesity, which is the core, that drives many of the downstream risk factors.
Very clear, very clear. And as you were talking about obesity and infection, I thought of COVID. I remember during COVID, that was one of the big things that came out early on as we were trying to understand it, is that the people who seemed to do the worst, at least one of the significant risk factors was in fact obesity. So I think that was one of the early signals that there's a link. So, okay, I think you've been extremely convincing, Naveed, as per usual. So how much weight loss should be achieved, and what factors go into answering that question?
So this is a trickier one. I mean, if you think about it, if we have the average patient who comes at diagnosed with diabetes, if we could get them all to lose an average of 10 kilograms, we will get 50% of them will have remission. If you can get them to lose 15 kilograms, maybe 80% will have remission. Some will not, and some will have not only have remission, they'll have complete remission. The glycemia normalizes down to a hemoglobin A1 of 37. So you get a range of effects. Partly that depends on your other threshold aspects. How far from the threshold of normal glycemia were you when we got you diagnosed, depending on your genes, your ethnicity, your age, your sex, and all these aspects. So I think, we probably could work out, based on lots of evidence, what roughly should be the threshold. The ideal scenario, though, is if I had, for example, for an individual, hemoglobin A1 levels over 5 years, and I could see it tracking with weight. It won't be completely linear, but it's broadly linear. You could say, well, roughly, look, we've diagnosed your diabetes now, your hemoglobin A1 is 54, but actually, looking back 10 years, when you were 15 kilograms lighter, your hemoglobin A1 was 42. Mm-hmm. So, that's probably what we could work out. But the reality is, whatever is realistic, whatever is sustainable, whatever is achievable, and whatever is desirable as well for the patient, those are the three things that matter, I think.
Perfect. Yeah, I would agree. So, okay, now let's talk about how to achieve this weight loss and early remission. And within the paper, you discuss the pros and cons of various options, including low-calorie diets, incretin-based weight loss meds, bariatric or metabolic surgery. And I encourage our listeners to read that excellent review in the paper, and we won't have time to go into each of these in the context of this podcast. But with these potential strategies in mind, how do we achieve the large-scale part of your proposal? Because that was another sort of key part that I took out, was that you wanted this to be large scale. So how do we make that happen?
Yeah, I mean, I don't want it to be large scale for my purposes. I want it to be clearly large scale for the purposes that many people with diabetes who could actually have it delayed for 10 years, if we were able to do these interventions. Now, we're starting to do large scale in the UK. We've got low-calorie diets, which are rolled out in the NHS in Scotland and England now, and thousands of individuals have benefited. So that does work, but clearly weight, as in our main figure, generally does track back up, in part, and we'll come on to this, is because the environment is pulling them back on to put weight back on. The ideal scenario, if the evidence for incretins continues to be good and the benefits substantially outweigh the harms, then having incretins which were more affordable would be the way to go. Perhaps orals in some ethnic populations who need less weight loss to get the remission, for example. So my sense is we're not there yet. The cost of many newer weight loss interventions, obesity medicine, for want of a better expression, they're still very expensive. But 10 years down the line, Alice, if you and I had the same conversation, some of them will be off patent, there'll be more competition. The costs will be probably much more affordable for either the individuals or healthcare systems to be able to really implement this at the point of diagnosis of diabetes, and perhaps even, and some people wish it in pre-diabetes, even then. And I think that's what we will see. At this moment in time, that 10 years might be 20 years for low and middle income countries. Professor Mike Lean, who's a brilliant colleague of mine, he's doing trials, which I'm helping a little bit with, in low and middle income countries where we're repurposing foods as low calorie interventions, their own foods. And we're trialing those things that they do seem to work. For example, dal can be made into an 850 calorie type portion over the course of a day. So low calorie diets, incretins. But again, if depending on who you speak to, some of my colleagues say, well, the primary pathology in most people is actually the appetite signals. So really incretins should be the real intervention. But for now, I think low calorie diets and incretins, perhaps a mix of these going forward. But over time, my sense is if the evidence and the safety of incretins remains as good as we see it as it is now, and with the evidence emerging, I suspect in 10 years' time, we will be using obesity medicines at the point of diagnosis in people with type 2 in many parts of the world.
Mm-hmm. Now, there's still a number of gaps in knowledge, though, and you list, I think, 8 of them in the context of the paper. So what are some of those gaps?
Yeah, I won't go through them, as I say, for time. I think I've already alluded to it. How do we mix interventions? Maybe there are possibilities we can start people on low-calorie diets to lose a lot of weight, and we just need to give them intermittent incretin to keep their weight down below their threshold. So, mix of interventions, intermittent use of incretins in some, if they don't have end organ damage that requires longer term and consistent incretin therapy. The other question is if, say, in 10 years' time, we do start someone who, say, has got a BMI of 34 on an obesity medicine, weight lossing therapy, they lose, say, 6 units of BMI, their glycemia normalizes. Do we still need to add SGLT2 inhibitor in that individual? Or do we only add it when their risk for kidney disease and heart failure becomes more manifest? Is going to be a question. The other question is, do we target everyone with type 2 diabetes? I mean, it's type 2 diabetes is not homogeneous. Young person who I saw in a clinic this morning with type 2 at 40 is completely different from a person who develops type 2 at the age of 85. And my sense is the initial target should be more younger people, perhaps those under 55, living with obesity, rather than everybody, beyond that. Just because, we don't have the funding for everybody, and also because the lifetime risk of complications is much higher in younger people who develop diabetes, partly because they have it for longer, and also partly because they have developed diabetes at higher BMIs, so they have a greater obesity-driven disease, as it were, that accelerates many of the other risks to a greater extent faster than someone who develops diabetes at 75, shall we say. So those were some of the kind of elements we were discussing. And I suppose one other key thing is, to what, do we give up on lifestyle? The answer is absolutely no.
No.
Absolutely no. It's absolutely the opposite. I think with low-calorie diet, that is, of course, a lifestyle intervention. But when you have an individual on a obesity medicine which targets appetite control, they probably do have a capacity to, and mental space. I'm not saying in every case, but in many more cases, and I see this clinically, to be able to think about activity in a way that they hadn't done before, because they're not thinking about food more of the time. They have a capacity to think about different diets. So what we now need to do as a health profession is how do we best help people overcome the obstacles and increase their imagination and give them the self-efficacy to be a bit more active, to get more fun out of activity and eat a bit better, so that if they can't take the incretins or weight loss therapies forever, they have made some sustainable changes which will then slow their weight regain should they not have affordability of that therapy. So that's what we need to do, I think, going forward.
Okay, so still a lot of work to be done, a lot of questions to answer, but I think we're getting closer and closer.
Absolutely.
With time. So this.
Yeah, sorry, Alice, there's one other
Please,
thing I
yeah.
forgot to say is, and this really matters, really in terms of how much, if I have somebody comes to me with a hemoglobin A1 of 49, and we've checked their eyes, they're completely clear, their kidney function is completely normal, and we give them obesity medicine and the hemoglobin A1, and they lose, say, 15 kilograms, and hemoglobin A1C goes down to 41. How often do I need to follow them up? Do I need to keep doing all these diabetes tests? And the answer is probably no. My sense is we need to reimagine what clinical practice could look like for that individual. And that is really important because we want to save a lot of the costs that require, yearly retinopathy, for example, or kidney tests, or bringing the patients to do, and perhaps we can do away with having to require metformin and many antihypertensives. Not every antihypertensive, because some people still need them. So can we reimagine care so it's much lighter, much more efficient, and maybe just do a yearly hemoglobin A1 and pick those people going back up towards the threshold to do another intervention at that point in time?
So, with that thought, like that individual that you would have just described, then perhaps this is a silly question, and feel free to tell me it's a silly question. But let's say someone achieves remission using incretin based therapies, remain on incretin based therapies because it's helping them to maintain where they need to be. Have we actually achieved remission? Is there actual disease modification? Does it matter? The person's doing well, their risk factors have reduced. So is that even a relevant question?
Yeah, no, that's a brilliant question. It's not a silly question at all. It's, to my mind, it's partly semantics, because what we want for the patient in front of us is to be able to help them not develop complications, lead healthier lives, and not, as I say, develop end organ damage. And we are going to be doing that if we give obesity medicines. We're going to be substantially improving their quality of life, because they generally, with lower weight, have a capacity to move better. They feel, generally, not in every case, they feel happier with the way they look, and they then have less toxic lipid, toxic glucose, toxic hypertension, as it were. That means they're going to get less end organ damage. You're going to really substantially help their lives. And that's what matters. I think the key question is really insurance. If they've had diabetes, what insurance category should they come in? And actually, once we give them the therapy, imagine somebody who went from, say, a hemoglobin A1 of 47 to 51, and we give them an incretin, they go back down to 44, or even 47, shall we say, they're on incretin. Because incretin does other things beyond weight loss and has a direct effect on atherosclerosis and sugar and kidneys, they're actually healthier than they were when they were not on the incretin at 47. Yeah. So we need to change the way we define these individuals. I think we should call it remission, and we should change the insurance bracket for these individuals as well, because all the evidence we have is that their risk for future disease is substantially lowered in many ways. That's what we should be doing. Yeah.
You heard it here, insurance companies, as to how we need to approach this, because I completely agree. Now, I do want to end with this important question, because this emphasis on early targeted large scale weight loss as a central strategy in type 2 diabetes makes a ton of sense and does have the potential to completely change the trajectory.
Yeah.
But how do we implement this without perpetuating the stigma that type 2 diabetes is a lifestyle disease? Because in the general public, that is unfortunately still quite prevalent and quite damaging. And this kind of supports that, but it doesn't, based on the biology, right? So how do we walk that line?
Yeah, I know that is an absolute brilliant question. And I've learned a lot from many colleagues listening. I mean, I had a brilliant talk from Lee Kaplan recently on this as well. And some of the things that Lee said really resonated with me. I mean, the reality is, and I've written a couple of papers recently, again, learning from lots of colleagues in Oxford and many other places. Obesity is predominantly not about willpower, it's the environment. The environment these days is so much more obesogenic than it was in 1980 when I was growing up. Levels of obesity in the UK in 1980 were about 6%. We had about 2% living with diabetes. Now, obesity is 30%. We have almost 10% living with type 2 diabetes. So the vast, vast majority of our patients are not lazier or greedier than they were in previous generations. It's not about willpower, it's the environment. The genes are still the same. The appetite signals, there's a range of appetite susceptibility. But what's triggered that susceptibility to pathogenesis is the environment. The way I describe these drugs in one paper is that they provide a chemical shield to the obesogenic environment. That's what they do, and that's the primary pathology. So we need to educate all of our colleagues not to give people a hard time, that actually, for the vast majority, they do not want to be living with obesity. They've tried the best in the context of their life, their genetic makeup, their food environment, and all of their lifestyle not to be living with obesity. But if we can then give them a chemical shield to the environment, we can manifestly help them reduce weight in a sustainable fashion that substantially reduces their burden of disease and help them lead healthier lives. So that stigma aspect has to change, absolutely has to change. We got it wrong for many, many years. Oh, you're overweight, go and lose weight. We gave patients a hard time, and it was completely the wrong thing to do. So we need to educate all of us, our colleagues, in that same mode going forward.
Love it. Always love chatting with you, Naveed. Always love chatting with you. That the passion is just palpable. So that's wonderful. So thank you. Thank you very much, Professor Naveed Sattar. We are in a different era in type 2 diabetes care, and I'm so excited for what the future is going to bring. But I think we have a responsibility as a diabetes community to ensure that these innovations and advances are made as equitable and accessible as possible from a global perspective. So thanks again, Naveed, for sharing your expertise with us today. And I encourage our listeners to read the full article in the May 2026 issue of Diabetes Care.
In the May 2026 issue of Diabetes Care is a feature article entitled Glucagon-Like Peptide 1 Receptor Agonists and Risk of Non-Arteritic Anterior Ischemic Optic Neuropathy in Patients with Type 2 Diabetes. I'm delighted we have joining us the article's senior author, Dr. Laurent Azoulay. Dr. Azoulay is professor of epidemiology, biostatistics, and occupational health, and a senior investigator in the Lady Davis Institute for Medical Research at McGill University in Montreal, Canada. Welcome, Laurent.
Thanks so much, Michael. It's really a pleasure to be here.
And congratulations to you, Laurent, and your co-authors on this feature article. To get started, and given its rarity, I was hoping you could please explain the condition of non-arteritic anterior ischemic optic neuropathy and what differentiates this from arteritic forms of anterior and posterior ischemic optic neuropathy.
So, NION is basically an acute loss of blood flow to the front part of the optic nerve. And patients typically present with sudden, painless vision loss, and unfortunately, it's often permanent. The key distinction is that non-arteritic, meaning that it's not caused by inflammation like giant cell arteritis. And that's important because arteritic forms are emergencies and they're treated very differently. NION is more related to vascular insufficiency and patient susceptibility.
Okay, and so what led you to study this condition in the context of GLP-1 receptor agonist use in type 2 diabetes? And how did you design your approach?
This really came from emerging safety signals. There were reports suggesting a possible link between GLP-1 receptor agonists, especially semaglutide and NION, but the evidence was quite inconsistent. So we wanted to take a more rigorous approach. We used a large UK database and compared new users of GLP-1 receptor agonists to new users of DPP-4 inhibitors, which are used at a similar disease stage in the UK. And we designed this study to mimic a randomized control trial as much as possible using real world data.
Okay, and so what did you find?
What we found was a higher risk of NION shortly after starting a GLP-1 receptor agonist. At 1 year, the risk was about 2.5 times higher compared to DPP-4 inhibitors. But I think it's really important to emphasize that the absolute risk was very small. Also, the signal seemed to be concentrated early after treatment initiation, within the first 6 to 12 months, and then it attenuated over time.
That's super interesting, especially seeing that early signal in risk. And given the greater efficacy of GLP-1 receptor agonists than DPP-4 inhibitors for correction of hyperglycemia, did a greater reduction in hemoglobin A1C relate to the increased risk for non-arteritic anterior ischemic optic neuropathy observed in your study?
Yes, that was actually quite interesting. We did see that patients who had larger reductions in HbA1c tended to have higher risks. So that points toward a possible mechanism related to rapid glycemic improvement rather than a direct toxic effect of the drug. It's somewhat analogous to what we've seen with early worsening of diabetic retinopathy with insulin, for example, when glucose control improves very quickly. That said, these were exploratory analyses, so they should be interpreted cautiously.
And that's a great point because we do think about this often in terms of our patients with diabetic retinopathy to ensure that any proliferative or severe non-proliferative disease is treated before instituting new therapies. But did you see if a presence of any diabetic retinopathy might affect the risk for experiencing non-arteritic anterior ischemic optic neuropathy?
So that's a great question. So in this study, we didn't specifically show that diabetic retinopathy itself modifies the risk. We adjusted for it as a marker for disease severity, but unfortunately, we didn't have the statistical power to see any clear independent effect. That said, it's certainly plausible that patients with underlying microvascular disease, such as diabetic retinopathy, could be more vulnerable, but that's something that would need more focused study.
Terrific. And do you have any additional points or key takeaway messages for our listeners?
Absolutely. I think the main takeaway is really about balance and awareness. First, NION, as you've mentioned, is very rare. So the absolute risk remains low. Second, if there is a risk, it seems to be early on after treatment initiation. And third, and maybe most importantly, these drugs have known major benefits for glycemic control, body weight, cardiovascular outcomes. So this is not about avoiding them, but about being aware of a potential rare adverse event and monitoring patients appropriately, especially early on in the treatment.
Dr. Laurent Azoulay, thank you so much for sharing your expertise with us today. I really appreciate all I've learned from your article and our discussion about the risk of non-arteritic anterior ischemic optic neuropathy and a better understanding of the condition and how that may relate to early period after initiation of GLP-1 receptor agonists in our patients with type 2 diabetes. I encourage our listeners to access the full article in the May 2026 issue of Diabetes Care.
Let's move on now to the Rapid Exchange segment, where Mike and I will discuss articles we found of particular interest this month. So, Mike, can you kick us off, please?
Sure, Alice. My first pick examines the metabolic effects of the GLP-1 receptor agonist semaglutide in patients with schizophrenia treated with second-generation antipsychotic agents, complicated by having overweight or obesity and prediabetes. Dr. Ashok Ganeshalingam from Odense University Hospital and colleagues in Denmark evaluated measures of beta cell function and insulin sensitivity from a randomized double-blind trial of 104 participants who were assigned 1-to-1 to treatment with either semaglutide 1 milligram weekly or placebo for 30 weeks. The previously published primary outcome demonstrated a 62% increase in prediabetes remission in those individuals assigned to semaglutide therapy. Now reported, the approximately 9 kilograms of average weight loss seen with semaglutide mediated a significant improvement in insulin sensitivity, explaining the reductions in fasting glucose and hemoglobin A1C that were observed, with no significant effect on beta cell function. And since second generation antipsychotic agents are known to impair insulin sensitivity, even independent of their associations with increased body weight, it is nice to see mechanistic evidence for GLP-1 receptor agonist therapy to directly combat the metabolic disturbance induced by these agents for the people who depend on them.
Thank you for sharing that one, Mike. I mean, this is really important information, and we're starting to see more multidisciplinary type teams come up when it comes to care for people with mental health diseases because there is so much overlap between the disorders themselves and metabolic disorders, but also the treatments that are offered to treat the mental health, in this case, schizophrenia, and the metabolic consequences. So it's nice to see some multidisciplinary crossover and then understanding of how this is actually helping. So this is very helpful. Thank you, Mike. So my first two picks this month have a pediatric focus for a change. My first pick is an important Canadian study looking at the cost effectiveness of general population versus targeted islet autoantibody screening at alternative ages and frequencies to detect early stage type 1 diabetes in Canada. Dr. Shweta Mittal and colleagues used a hybrid decision tree Markov model to compare 6 strategies defined by different populations, i.e., general population versus high genetic risk or family history, frequency, and age of screening. These were all compared to the idea of no screening. Costs were estimated using the Canadian health system perspective. They measured effectiveness as the number of at-risk children detected, general population screening at age 4 compared to family history-based screening at ages 2 and 6, cost about $405,000 more, but detected 35 more cases per 10,000 children for an incremental cost-effectiveness ratio of about $11,383 per case detected. In contrast, general population screening at ages 2 and 6 detected 18 more cases, yielding an incremental cost of $25,923 per case detected. Now, screening only those at high genetic risk involved higher cost and fewer cases detected. Bottom line, they demonstrated that general population screening detects more at-risk children than targeted approaches, with incremental cost per case detected at levels that are comparable to other pediatric screening initiatives, such as for cystic fibrosis. Now, what is not factored into this analysis is the potential impact of disease-modifying therapies that delay the onset of stage 3 T1D on the cost-utility analysis. And again, I want to remind everyone that this is Canadian dollars that we're talking about, and not US dollars.
Well, it's so interesting with all we've been learning recently from the use of polygenic risk scores. I was really surprised to see that the high genetic risk approach did not bear more fruit, but it does kind of make sense since we know that more individuals who have type 1 diabetes do not have a family history. And so for broader population-based approach to screening, probably does a better job to identify those individuals. I'll stick with your pediatric theme for a moment, Allison. With my second pick, Dr. Jancha Weiskorn from Hanover, Germany, and colleagues investigated the prevalence of elevated LDL cholesterol in youth with type 1 diabetes and the use of cholesterol-lowering therapy in this population. Among more than 55,000 youth in the DPV registry with at least one measurement of LDL cholesterol, almost 10% had hypercholesterolemia, defined by an LDL cholesterol concentration greater than 130 milligrams per deciliter. What is concerning is that only 7% of children with elevated LDL cholesterol were receiving any lipid-lowering therapy. And of those treated, only 16% achieved the recommended target of less than 100 milligrams per deciliter in childhood. So these results highlight both an unmet need for attention paid to dyslipidemia among youth with type 1 diabetes and an opportunity for intervention to hopefully reduce the risk for future cardiovascular disease.
And this reminds me of one of our rapid exchange discussions from December 2025 that looked at a database as well and also identified low levels of identification and low levels of treatment. So this is something we need to all bear in mind. And I think some of it comes down to some of the lack of statin acceptance, if that's the best term to use, that definitely exists in adults. And I can only imagine what that's like in children, in that probably that conversation can be more difficult because the parents may also fall into that whole I don't believe in statins thing. So I think it behooves us to first find these children and then make sure that we have those conversations to try to treat more people. My second pick is a phase 2 randomized placebo-controlled trial of high-dose oral insulin in children with stage 1 T1D, which is the presence of 2 or more islet autoantibodies with normal glycemia. Professor Annette Gabriel Ziegler and colleagues from the FRIDA insulin intervention trial randomized 220 children to receive daily oral insulin or placebo for 12 months. Dysglycemia, or diabetes, developed in 87 participants with no statistical difference between the oral insulin and placebo groups. The 5-year progression rate was 40% in both groups. No difference was observed as well for immune response to insulin between the two groups. So bottom line, in children with stage 1 T1D, 1 year of high-dose oral insulin did not alter progression to dysglycemia or diabetes or the immune response to insulin.
Well, I am sure these results will land as a disappointment to many who've long hoped for the possibility of desensitizing the autoimmunity of type 1 diabetes. And stage 0, really before any autoantibodies are detected, may be the therapeutic window for future investigation. My final pick addresses shrunken pore syndrome, which is not what you think, or at least it's not what I thought when I first read it. I immediately thought of skin, saunas, and sweat, but this syndrome is affecting the glomerular pores in the kidney. And clinically, shrunken pore syndrome is defined by a discrepancy between measurement of estimated glomerular filtration rate based on serum cystatin C relative to that based on serum creatinine. And this is due to the larger relative size of cystatin C as a molecule compared to creatinine. Dr. Valma Harjitsalo from Helsinki, Finland, and colleagues examined 3,769 participants from the Finnish diabetic nephropathy study who had both serum cystatin C and creatinine measures available to categorize as having shrunken pore syndrome or not based on a ratio cutoff of 0.7. While in individuals who also had albuminuria, shrunken pore syndrome was associated only with a modestly increased risk of heart failure. But in individuals without albuminuria, having shrunken pore syndrome was associated with a threefold increased risk for heart failure, peripheral arterial disease, and all-cause mortality. So for individuals in the absence of albuminuria, measuring cystatin C-based estimated glomerular filtration rate and its ratio to creatinine-based assessment may aid in earlier identification of individuals at higher risk for kidney disease-associated cardiovascular morbidity and death.
That's very interesting. I have to say, I had never heard of shrunken pore syndrome before. And I do feel, and I hope I don't offend people as I say this, that it's going to suffer from some marketing because these people need to change the name for shrunken pore syndrome. Because I really do think that as a biomarker, this concept is very cool because we have the presence of an elevated UACR, so albuminuria, as not just a marker of risk for kidney disease progression, but cardiovascular risk, heart failure risk, et cetera, et cetera. But for those without albuminuria, this sounds like a potentially powerful tool, but it really needs a different name. And it's the cystatin C creatinine ratio, or I don't know, something that smarter people can come up with. But this is very interesting, and I'll be interested to watch what happens over time and as this gets adopted into clinical practice. So my final pick is a study by Dr. Christine Chan and colleagues from the United States. They sought to determine the utility of a non-fasting 50-gram, 1-hour oral glucose challenge test as first-line screening for cystic fibrosis-related diabetes and pre-CFRD. So 185 participants without known diabetes had baseline random plasma and capillary glucose, 1-hour 50-gram glucose challenge test, A1C, and traditional OGTT performed on separate days. The 50-gram GCT had an area under the receiver operating characteristic curve that was higher than random glucose or A1C. A GCT threshold of 147 milligrams per deciliter, or 8.2 millimoles per liter, provided 90% sensitivity and 58% specificity for detecting CFRD, and would importantly reduce the number of required OGTTs by 56%, sparing low-risk individuals from the discomfort and burden of a full-on oral glucose tolerance test.
And we know the traditional oral glucose tolerance test requirement for fasting and 2-hour samples is challenging for so many to complete. So having a non-fasting, potentially in clinic 1-hour test alternative should really help to improve screening completion rates that are really quite low in our population with cystic fibrosis. Well, this brings us to the end of the May 2026 episode of Diabetes Care on Air.
And we want to express our thanks to Doctors Laurent Azoulay and Professor Naveed Sattar for sharing their expertise with us.
And a reminder to all that Diabetes Care Journal is continuing to take submissions of original art for consideration to be included on a future journal cover. So don't be shy. And don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening to another episode of Diabetes Care on Air.